From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, I'm Dr. John Inadomi. I serve as chair for the Department of Internal Medicine at the University of Utah and an associate editor for JAMA. Today, we'll be discussing an original article titled Screening for Helicobacter pylori to Prevent Gastric Cancer, a pragmatic, randomized clinical trial from the lead authors Drs. Li and Chang and the collaborators of the Taiwan community-based integrated screening group. And I'm very pleased to introduce our discussant, Dr. Constanza Camargo, who is an Earl Stobben investigator at the Division of Cancer Epidemiology and Genetics at the National Cancer Institute. Her research focuses on Helicobacter pylori infection, pre-malignant gastric lesions, and gastric cancer. Dr. Camargo's program combines studies on cancer causation with projects that have translational application for cancer screening, prevention, and treatment. Dr. Camargo wrote the editorial accompanying this article for JAMA that provided the context of this work and highlighted the clinical impact. Welcome, Dr. Camargo.
Thank you for having me, Dr. Inadomi. Excited to be here.
Yeah, thank you. So let's start off with kind of the general context. Now, there are published studies, including randomized controlled trials of the impact of Helicobacter pylori eradication on the reduction in gastric cancer incidence mortality. So why is this study different? And what have the authors added to our knowledge?
Thanks for the question. This trial is important as it tested a primary prevention approach for gastric cancer, a leading cause of cancer death globally. Chronic H. pylori infection is the primary cause of this malignancy. It is responsible for at least 80% of the new cases. Results from observational and explanatory randomized trials have shown that H. pylori eradication reduces both incidence and mortality by about 40%. Similar benefits are observed in patients after resection of early gastric cancer to prevent metachronous cancer and first-degree relatives of gastric cancer patients. However, there are limited data on how screening to detect and treat H. pylori works in the real clinical settings. Thus, this innovative pragmatic trial conveys valuable insights for gastric cancer prevention with potential application to countries with variable gastric cancer risk.
Thanks so much. So it really is the implementation of the screening for H. pylori in addition to just knowing that H. pylori eradication can impact gastric cancer incidence mortality. So thanks so much. So now that we have that as a background, can you summarize, let's say, part of the study design and particularly how it results of the study results and how they impact us?
Sure. Let me start by congratulating the team led by Dr. Li and Chang on a large-scale, well-designed, community-based pragmatic trial of H. pylori eradication in the context of a screening program for colorectal cancer. During the period 2014 to 2018, the authors randomized 240,000 Taiwanese individuals aged 50 to 69 years and invited about 90,000 of them to receive a fecal immunochemical test, FIT, and 64,000 to receive both FIT and an H. pylori stool test. Adding an H. pylori test increased the participation rate by 14%, resulting in a faster enrollment as compared to the FIT-only group. The H. pylori prevalence was relatively high, 39%, and the eradication rates among H. pylori positive referred individuals were greater than 90%. All the participants were followed until 2020. Related to the results, in the randomized analysis, there was not significant difference in gastric cancer incidence or mortality between the groups. The authors conducted a more refined as randomized analysis and adjusted for non-adherence and baseline characteristics. And the incidence of gastric cancer was significantly lower in the group randomized to FIT and H. pylori testing. It was about 20% reduction. In the fully adjusted as treated analysis, adding an H. pylori test significantly reduced both gastric cancer incidence and mortality. And the magnitude was about 40 to 50%.
Well, thanks so much. It's really helpful to hear the kind of the context of the study design. And probably the unexpected result there was that, as you pointed out, the uptake of screening was much higher in the people who were getting the HP stool antigen test plus the FIT compared to people who were getting the FIT alone. And it must have been something about they kind of knew that gastric cancer screening was something that was good for them. And maybe that's why they were more apt to uptake that test. And so that, again, these are kind of the unexplained or the unexpected results that you have to adjust your study for. So it's really important to understand that context. Were you surprised by any of these study findings then?
The pragmatic trials are different as compared to the explanatory trials. This particular pragmatic trial aimed to test the effectiveness of the invitation to undergo H. pylori testing along with FIT. The authors clearly acknowledge the major differences in intervention adherence that make the pretreated analysis likely biased. As mentioned, the participation rate was higher in the FIT and H. pylori testing group, and there is differential follow-up time between the groups. Also, individuals in the FIT and H. pylori testing group had a greater number of risk factors for gastric cancer, and the differential risk of mortality only emerged after the adjustment for non-adherence and baseline participant characteristics. I think that in general, these 5-year results are very encouraging, but we look forward for the long-term results as they will provide more insights and evaluate further safety concerns of H. pylori test and treat strategies.
Yeah, it's really helpful. And again, the part of the title is a pragmatic trial. Yeah, you can't force people to do stuff. So even though we wanted to know, gosh, does testing for HP and treating reduce gastric cancer? What we can really just test is an invitation to undergo screening associated with a reduction in cancer incidence. And so, best laid plans of mice and men, so often go astray. So you can only do a certain amount, and that's why this is a pragmatic trial. And that's why understanding both the intention to treat or the randomized group in analysis is important, as is the adjusted analysis that adjusts for, as you say, the difference in uptake between the two groups, as well as the per protocol, so who actually got the screening tests. And so that's really helpful. The other thing that I thought was quite interesting was that in the group that had the HP stool antigen testing, those who were positive, there seemed to be a higher rate of colon adenomas. Can you comment on that?
Yeah, that was interesting. There is growing evidence suggesting that there is an association between H. pylori infection and colorectal cancer. And I was very skeptical about this. This association will not have the magnitude of the association that we see with gastric cancer, but I think that is important to study it. Yes, the authors report that there was a lower incidence of colorectal cancer in the FIT and H. pylori testing group, suggesting a potential partial benefit of treating H. pylori infection. I think that further research could shed more light on the role of chronic H. pylori infection in colorectal cancer.
Yeah, it's fascinating. But as you point out, I would say this is more hypothesis generating than definitive at this point. But interesting results that are somewhat backed up on, I would say, mechanistic studies that are published in the literature already. How about limitations of this study? Anything you'd want to bring up? And in particular, let's say generalizability.
I think that this trial was very informative, and we all learned from the limitations that were clearly stated by the authors. I think that is really critical for future studies to use accurate tests and high participation. I think that those are the key components of this trial that we can extrapolate to new studies.
Great. And finally, the punchline is the clinical impact. And well, do you think we should start screening for H. pylori in the U.S., specifically to reduce gastric cancer?
Yeah, that is a key question. Yeah. As recommended by several international guidelines, I think that the first step for the U.S. will be to conduct some demonstration projects of H. pylori test and treat strategies in the well-known high-risk populations. NCI has a growing interest in the gastric cancer research agenda. As an example, this year we hosted the first think tank on advancing gastric cancer prevention. During this meeting, an international multidisciplinary group of experts reviewed the state of the science, identified critical knowledge gaps, and also proposed some future directions. I think that the primary prevention studies of gastric cancer in the US could be modeled after the insights of this very informative pragmatic trial. The results show that implementation of H. pylori test and treat strategies is indeed possible using screening platforms that are already in place. I think that some new studies are really useful. Any new study should also align to the clinical guidelines of the American College of Gastroenterology and other professional societies. Related to potential populations to study, I think that Alaska Native communities have a higher burden of H. pylori, gastric cancer, and especially colorectal cancer, making them a priority group that could benefit from novel interventions.
Well, that's wonderful. So, Dr. Camargo, thanks so much for taking the time to explain the study and for your insight about the clinical impact of these findings. And we really appreciate all of your expertise and your experience.
Thank you, Dr. Inadomi. It has been a pleasure.
I am Dr. John Inadomi, and I've been speaking with Dr. Constanza Camargo about screening and treating Helicobacter pylori to reduce gastric cancer incidence and mortality. You can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.